We'll go on to the next session. That was a wonderful pro-con session. The next session will be on approach to undifferentiated fevers in ICU. We have Dr. Rajesh Mishra from Ahmedabad, who is an intensivist, who is going to speak to us on undifferentiated fever.
So, it's almost good evening, and still a lot of audience on very common topic. How do you approach to undifferentiated fever in ICU? In fact, this is one area I tell you that not much has been done, particularly not only from India but across the world. There are very few studies where people have tried to find what is the cause of undifferentiated fever in ICU and how to approach, what is the ideal way to approach. And most of us has our own way to find and diagnose fever in ICU. So, whenever you have a patient, particularly I'm talking about patient who is there for more than 48 hours in ICU and develop fever. So always remember what is the primary pathology, why patient has come to us. And those who develop fever, you have to differentiate between infection and sepsis. While infection and sepsis, infection means controlled immune response and sepsis means uncontrolled response. Sepsis is bad, you need to act quickly. Infection, you have time to find the source and control, and you have time to start antibiotic. So it's also important that you try to find out why somebody has fever. And then, as I said, that this is an area where you have to look at. Many times when my septic patient develop fever, I feel happy. I feel happy because most of the septic patients are immunosuppressed, they are inotrope, they are on vasopressor, they are down. But when we develop fever, that means whatever you have done, their immune system now started responding, and probably its immune system is behaving in a better way, and that's why fever in septic patient is a good as long as it's a sign of good immune response. You will have fever, but clinically you will find patient stable, or maybe his look will change, his facial expression will change, his hemodynamics will change. So if that happens, that's a good sign. But if septic patient develop fever and become unstable, oxygen demand goes up, patient become hypotensive, patient become more tachycardic, then that is bad, and that means that fever also has to be controlled, and you need to find out why patient has developed fever. So this is another point which we have to remember. Some fact about the fever, that we all know that fever, if it is above 103 degree, irrespective of cause, and if it persists and you are not able to diagnose and treat the cause, it carries high mortality, high increased length of hospital stay, particularly in a patient of traumatic head injury, subarachnoid hemorrhage, or pancreatitis. One of the most worrying issue with fever is the moment patient has fever, we order battery of investigation without trying to find that is this fever good or bad, is this fever appropriate response or inappropriate response. And that adds to the cost, lot of cost to the patient. Diagnosing sepsis is probably one of the most expensive affair to diagnose, and still you may not find anything. Whenever you have fever, be always, it's not only good or bad response, it's not only infection or sepsis, we also need to find that this is infectious or non-infectious. Many a time, lot of non-infectious disease, they get flared up with sepsis, a bit viral infection, particularly adrenal insufficiency, particularly subclinical hypothyroidism, particularly many a time drug reaction. So if you have tried to find the source, which is a common, and common source are like in ICU bacteremia with metastatic pneumonia or catheter-related infection. Wherever you have breached this normal security of homeostasis, infection can come from there, and you have to look that side. But if you do not find after a routine investigation that probably patient has worsened due to sepsis, you should also look for the non-infectious cause. One of the clinical features which will guide you to differentiate between infectious and non-infectious is, if it is an infectious fever, most of the time your patient will go towards the downtrend. And there is a lot of study, a lot of observation is being done on facial observation. This facial, if you look to the facial, his facial expression, that will change very rapidly. And if it is non-infectious fever, most time your patient will not worsen that fast or may not become unstable, and maybe he will clinically look good. So if you are continuously observing your fever, patient and particularly noting his facial expression, that may give you a clue to differentiate between infectious and non-infectious. Because the cause of non-infectious fever are very important, and sometimes they need very specific treatment, otherwise you will not be able to control the fever. So I approach fever like that, try to find the likely cause. What is the grade? If it is less than 101 degree fever, many a time it can be the infective, non-infective, but I will keep a watch. Somewhere fever between 101 to 103 degree or 104 degree is most common cause is infection, particularly bacterial infection is the most common. Viral and fungal can be there, but bacterial. And another thing which you have to remember, that in ICU patient there can be, if it is sepsis, there can be more than one infection, that also you need to keep in mind. Immunosuppressed patient on life support, particularly CRRT and ECMO, may not show any sign of fever, even they develop bad sepsis, that we have to remember. So you go for a targeted history. When I say targeted history, you should be knowing what patient has come for and what has changed. Suppose a patient, a common thing, blood is on ventilator, with central line, more than 5-7 days, if develop fever, on catheter, these are the common side which you look if secretion has changed. Is the catheter side become red? Is urinary catheter, in urine there is a pus. So this is the common thing here. So wherever you have breached the normal body security system, which secures us from infection, first look to that. Another common site for ICU is abdomen, urine and chest. If that is clear, there is no bed sore, you have to go further for further investigation. But this is a common thing which you have to look further. And as I said, that fever between 102 to 105 is likely infection. Fever above 106 degree, if it comes, the first thing should come in your mind, mostly it will be non-infectious, mostly it will be central, mostly it will be drug-induced. So if somebody develops sudden fever for no reason, stable, and it suddenly goes up to 106 degree, that means your thermostat center is not able to control it, and you need to look for the non-infectious cause. Particularly in ICU, drug is the most common cause which can cause apart from other regions. Initial investigation, there is no set protocol. As I said, first you have to judge clinically what has changed, and then do the focus initial examination and investigation to find the cause. Ultrasound is helping us a lot in localizing the probable source, particularly in initial examination the way do. Now it's time for us to develop a fewer protocol through ultrasound, where a patient has become sick, patient has sepsis, quickly we can look for the chest, quickly we look for the IBC, we can look for the abdominal any fluid collection, we can look for the, if patient is drowsy, we can look for the optic nerve diameter, just looking for the. So very quickly in 2-3 minutes, a focused examination can help us in pinpointing the probable source of infection and doing the appropriate investigation rather than doing the battery of investigation to find the cause. So ultrasound driven protocol to find the probable source is something which we should start working on that. Apart from that, if you are not able to find some common cause like hyperthyroidism, Addison disease, And transfusion-related infection, particularly if patient has been given any transfusion, should always be kept in mind and investigated accordingly. Once you have established a provisional diagnosis, you try to focus on it, try to find out the result. Blood culture, probably if patient has fever, it's our routine that we just ask for 2 sets of bacterial culture. The thing which is changing and things which we want, if somebody has infection, somebody has sepsis, particularly bloodstream infection, we want to know the bug quickly, we want to know the sensitivity quickly, and that's the reason blood culture from the traditional culture to bacterial culture has now turned towards the multi-top system, or maybe finding the DNA rapid PCR technique, where we can quickly recognize the bug and probable resistance pattern. Purpose here is to recognize the bug quickly and also recognize the probable resistance. There is not an absolute test like culture sensitivity, but at least PCR based test can in 6 hours or so can give you a guide that what are the probable bugs are in blood and are they resistant or not. Initial treatment can be guided by that, but still you need to a blood culture and proper sensitivity report of backtech to confirm the diagnosis and start appropriate treatment. This is how the backtech multi-top system works. What multi-top has done, that it has decreased the time to diagnosis of the sepsis, of picking the bug, as well as picking the resistant bug early, and that's where I look for. But still, it is not ideal. Still, it is taking 24 hours or so, and we somewhere look, battery is gone down. Can we start charging, please, in laptop? Laptop is not being charged. Somebody can help me. Laptop charge nahi ho raha. It will. So so another thing which we have to get in our protocol is to get these point of care tests, particularly the rapid RT-PCR based test, to find the bug early, to pick resistance pattern early, so start appropriate antibiotic early. That's another thing. Then comes the management of fever. Definitely, there is no management of fever as such. You have to treat the cause and remove the source and probably treat the fever. So you have to treat. Initially, traditionally, there was a thought that sometime when we develop fever for infection, it's a viral or bacterial, and even up to 101-degree fever is good for protecting us, because fever is a protective response of the infection. And that's why it is said that up to 101-degree temperature, you don't try to control the fever. If it goes above 101 degree, or your patient become unstable, hemodynamically unstable or become hypoxic, then you should treat the fever. As far as source control is concerned, if you are sure that the source is central line or catheter, you need to change it. That you have to confirm the diagnosis by clinical examination or by looking to the trained in that. As far as the source removal is concerned, you have to always wait and balance between removing the catheter and its economic as well as procedure-related complication. If somebody is in DIC, in sepsis, on 3rd day of fever, having central line and develop fever and has tendency to bleed, you will think twice, thrice and 4 times before removing the catheter. You cannot remove it. So whenever you want to remove particularly catheter or lines as a source of sepsis, you need to always balance between probable source of sepsis, it is confirmed, is it causing sepsis? If it is not, source is something else you find, you can wait for it. So that's another thing. As far as treating underlying causes, as far as treating underlying cause is concerned, as I said that you need to find the bug, you need to find the appropriate culture and sensitivity report and start antibiotic. But I'm not going to talk about empirical antibiotic. Start empirical antibiotic, change your empirical antibiotic according to antibiogram of ratio. But my focus is that we should try to find, and RT-PCR based tests are definitely helping us in at least, why it's not moving? Helping us in finding the bug early. ये मूव नहीं कर रहा है स्लाइड आपके. As far as treating fever is concerned, antipyretics normally, particularly the only thing we prefer to give is paracetamol. If fever is making my patient unstable or is above 101 degree, we give initially for 24-hour 1 gram 6 hourly dose and then make it SOS. Try to see if patient fever is controlled. Many times patient needs devices to control fever when you are targeting fever to control targeted temperature management. Traditionally cooling of the patient, particularly cooling with ice and putting the air is something which is also being practiced and we also practice. What we have to remember then when we are trying to control fever, we should not induce shivering. If you induce shivering with fever, that will paradoxically cause more fever. It's the only one thing and whenever we are cooling down, the most important part of the body which has to be cooled down and where you need to put ice or air, whatever you want, is your head. Because that controls almost 55-60% of your temperature. Then part. What we do traditionally, we put sponging or ice cooling wherever on chest or thighs, but that will not control your temperature. If you want to control temperature, one area which you need to be really taken care is the head, because it has got maximum blood circulation and it is highly metabolic area, so you can control the temperature. I think my time is also going to get up, and this is laptop is also stop, so I will stop here. But one thing about the fever is probably we are thinking that this makes another area where we need to have our own indigenous data that what is the most common cause of fever in our ICU setup, and particularly how do we manage fever and how quickly we are able to diagnose the cause of fever in current scenario. Because I tried to see last couple of years there has been no study on this. So this make a case for a study. Thank you. That's right. It's done. It's done. It's not
Tha-
moving at all. Thank you.
Thank you, Dr. Rajesh. We'll go on to the next talk. We'll take up questions in the end.